I know you guys semi know, oops, sorry, semi know what the CDB is. So we'll go through a little bit of information on that. But then we'll talk about the operational database as well, which is the ODB, and that tool and some of the information on it. I'm not going to get too deep into anything, so just let me know if you have questions. We can talk through anything you guys need to. I would really like this to be a little bit more conversational than me just lecturing at you all. So, oops. All right. So you guys know the agenda, just went through that. Here, oh, sorry. Oh, that's weird. Thank you. Now, where's my cursor at? There. All right. Okay. So, Vizient is more than just the CDB. I know we've talked with you guys a lot about that, but our supply chain people know well that we have a GPO, which is a group purchasing organization. Lots and lots of information details in there, but that is kind of what we are probably more famously known for. And then the operational and quality perspective is the domain, is what we call it, the domain that I work in. So Tom gets to oversee both supply chain and quality, and he sees from that almost like thousand feet view, and gets to work with your teams more specifically across the whole organization instead of just quality or just supply chain. So Kim Aguilar is my counterpart for the supply chain aspect, and many of you might have seen or know her as well. So here are our analytic tools and the portfolio of analytic tools that we have. And let me move this so that I can see all of that information as well. So you guys participate, like we talked about, in the clinical database. We also have procedural analytics, which is more operating room focused, has a lot of supply information in PA as well. And then you have supply and pharmacy analytics. So that's your VSA and some of the other detailed information that goes more on the supply chain and pharmacy side of things. Then you also participate in something called the Clinical Practice Solutions Center. So that's CPSC, you'll hear us refer to that. And that is your outpatient pharmacy, or excuse me, sorry, outpatient information. Let me cancel or X out of this real quick so that we don't, oh well. And then we have the operational database, like we talked about, and then SG2, which is market analytics. So that works more in your strategy domains. I don't know who your SG2 person is, but Tom, if you say what? Oh, there you go. And they say it again. Okay. Perfect. So, and Tracy is your contact for SG2 from the Vizient perspective. And so, like I said, the ones that are highlighted in this goldenrod color are the ones that are in use by OU currently. I am having trouble advancing my slides here. There we go. All right. Oops. So you heard earlier Steve talk about why individuals or individual hospitals struggle to improve. So you have the challenge of not getting beyond data to change, which you guys probably have heard a little bit about. And there is some aspect of cleaning your data and making sure that it is properly reporting the information that you guys use and or see. And then challenge number two is not getting beyond the information to insights. So again, Steve talked about that. It's saying that you guys, or the data showing that you are different, but not necessarily why you are different. And then challenge number three is really not getting beyond the change. So you want to drive to decentralized improvement, and you don't have any leadership accountability. So I know you guys are looking into that right now. We're really working and focusing on, what that leadership structure looks like, how you guys want to organize that. And we can talk a little bit more about that later on, because I do want to hear how you guys are, planning to work on that, or what your current state is. So here's a little bit of the recommended structure from a Vizient perspective. So we have the step one is separating out, the major functions. Sorry, I have a hair in my mouth. For chief medical officers, chief information officers, chief quality officers. And you guys already have all of that in place. So then the step two is developing an executive balance scorecard. So I know you guys, again, are working on developing some of that. I know, Tennille, you've really kind of been deep into the data and trying to identify best next steps for all of that information as well. And then developing a process for accountability. Do any of you guys have any thoughts around that accountability? I know, Mubin, we had just spoke briefly about that. I'm more than happy to connect you with people who do that well. But any thoughts around that, or any ideas that you guys want to discuss, or spitball with us now regarding accountability or structure, and or how you see it moving in the future? Speak now or forever hold your peace. Nobody? Do you have any thoughts? Mubin? Yes.
Well, I mean, I think it's something that certainly and I think across like all the different providers, nursing, physician, all of that staff, and understanding what needs to be reported up, what are never events, and then having a larger system focus that would put more proactive with the data on whether it's a weekly, monthly basis. I think like the rush here that we have the data after a year, right? I want Q&A for, and now it's rush, right? But ultimately, I've said this to many of the groups, right? That data ended in July, and now we're in December. So the question is like, what are our paths to accountability, operating structure to move it forward? I think that's I think many of us have issue, I think.
Do you guys have safety huddles or anything along those lines currently, that where you talk about any sort of patient level information? Okay. And that happens at the same time every day? Okay, perfect. Awesome. So then centralized support and the triad, and I believe, Todd, you kind of already talked about this, how you guys are trying to do some triad approaches to having the physician, nursing leaders, and quality, maybe whether it be quality coordinators or improvement specialists or whatever. How do you guys refer to your quality folks here?
Quality.
Okay, coordinators.
So yeah, we've actually put that together. Put that together as far as the position component to the positions right now with us that is
perfect.
Taking on that role.
Yep.
We have identified quality coordinators that will be supporting to your dyad partner in those efforts. In fact, just conducted training between these two meetings today with our quality. So they're up to speed on pulling the standardized reports that we have created.
Great.
And then working with nursing members to identify our final pieces of triad.
Cool.
And then of course working with Melissa and risk.
Great. Awesome. Good steps. So this is an example, and again, you guys will get all of these slides. We are very, as you'll see from a at least in my opinion, we are very transparent with our information, more than willing to share any and everything. As long as we have access to it, you guys have access to it as well. So here is just an example of that balanced scorecard. Again, a lot of you guys saw some of this example when Steve presented earlier. So if you need assistance with any of this, just let us know. We're more than happy to help you, whether it be developing them or, assisting in rolling them out or whatever it might be. We're here, definitely here for you all. Oops. Yeah. Yep. Yeah, perfect. Yep. Yeah, perfect. Yes, I can definitely reach out to some of the organizations. I think people do it well in pockets. And some of what you may run across is that we have certain people that do it really well with CDB, or certain people that do it really well with ODB. And then maybe just off the top of my head, obviously, I don't know all 1,100 organizations and how they all operate, et cetera. But there may be a smaller group, especially, that we can talk to that have the same level, the same suite of data tools that you guys have as well. So hopefully I'll be able to connect and find somebody that has those three and how they integrate them and all of that fun stuff too. So perfect. So you guys, I'm not going to kind of read over this because there's a lot of words on here, but I think you all know how performance improvement works and really how to get there. And some of the information that can help you is available in the CDB, ODB, and CPSC as well. So here, Steve also talked about this. So the top 10 performers, what drives accountability and sustains results by engaging staff, really. So if you can get it down to the staff level, we can engage, or excuse me, not we, you all can engage from that bottom level up as well too. So it's always helpful to have your frontline leaders engaged. I know that it's been a process for you all to get there, and this is not just OU having the trouble. I will admit that this is a challenge for all organizations once they start with Vizient and or just starting in the process improvement journey in general, or the quality improvement journey in general. So you guys are not alone. You're not the only ones who have ever struggled or ever done it well or not done it well. So it's definitely an opportunity for most organizations, especially once they first come into the CDB and see that level of data and what it's telling them. So don't feel like you're unique in that sense at all. Oops. All right. So again, I'm going to probably skip through. You'll get these slides, but I'm going to skip through the CDB because we've kind of talked about that ad nauseum, I feel like. So I'm going to skip on to the ODB. Some of the information that you guys probably maybe don't know at the level is that you do have a CDB coordinator, that is Tennille. You also, from the Vizient side, have a Vizient product advisor. Geez Louise, I always say PA, and I always know that you guys don't know what PA stands for. Most people represent that with procedural analytics. So you have the CDB coordinator, and then from the Vizient side, you have a PA that supports you all as well. And then you have myself, which is the operations and quality executive. You have Tom T from a leadership perspective as well. So I think Tom said it best yesterday when we were kind of chatting just about his role and utilizing us as the Vizient staff is really, if you want to get your ROI out of using Vizient, use us as much as you can, because that's what we're here for. We are part of your suite of offerings, and we really are here to help you all improve as well. So that's kind of the CDB coordinator roles and opportunities that you can have there too. All right, so on to the operational database. So the operational database is used to be owned by IBM. So it's been through a few different hands. I think it was just a little over a year or two ago that Vizient actually purchased or fully gained access to you might have heard it referred to as Action OI before. So it is the operational database, and currently you guys do not have an ODB coordinator. So similar to Neil's role for the CDB, you would want to have an ODB coordinator as well. And that person, what I have seen is that person comes out of the finance department. So they are very involved in, how the financial system operates. They have more access to those financial metrics, et cetera. Not to say that they are just solely focused on finance and how finance works, but they understand the system as a whole as well, and knows the leaders in those areas and how to access them and how to ask them questions about or regarding the ODB and how your system operates and how that integrates into the information that needs to be entered into the ODB as well. Yeah.
I'll add.
Absolutely.
ODB, part of when Vizient was able to taking that tool from IBM allowed us to get into the back end of it. It's fairly labor intensive right now. They do enter data into that system. You're shaking your head, yeah. That's actually the owners, right? And largely the back end of it has changed for years. So it is from bottom to top being completely built on the back end to improve a lot of that. So, and what allows us to do from a dashboarding perspective, and the information coming out of it is going to be modern, not what we see today. So more to come on that, but I know you're looking to fill a role here. We're looking to integrate it into the scorecards, but outside of just the labor benchmarking pieces, there's good operational data in there as well. From a throughput perspective, EDOR, some lab metrics.
Assuming they're up to that, so there's the same ability that you look at your care group in there as with other aspects of the data that kind of down. It used to be much broader.
Yes, they did just recently align better with, so before it was just like an A group and a B group, and just recently they have, you can still do that as well, but they have separated out the cohorts to match. So those hospitals that are in the ODB that are also like a large specialized or an AMC, you can compare yourself to those like organizations. And it's easier to separate it out than what it used to be. You used to have to like go in and create your own custom comparator group, and now that's a pre-built. Yeah. And then hopefully that the new look is coming soon. Okay, perfect. So that hopefully you guys will, by the time you guys are able to get some data in there, you'll be able to see the new and updated information. Perfect. Perfect. So here's some unique features. Again, I'm not going to read through all of those. You guys will get this. But really to integrate it also with the CDB, it's not perfect. There are definite opportunities for improvement between the linking. But that's what I'm here for. I can help you with integration of those two, and looking at, if you have ODB, let's say supply chain metrics that you want to look at that align with the CDB supplies, et cetera. We can work on getting those and integrating them. Just yesterday, I was helping a hospital to look into the use of MRIs, and then we went over to RM and looked at resource manager in the CDB and integrating how, okay, if you're high here, what does the CDB tell you about your utilization, and are you higher than other like organizations, et cetera. So lots of ways that we can integrate some of that information. Again, here's some ODB roles and responsibilities. So you guys will want to identify executive sponsors, member champions, coordinators, and then on the Vizient side, again, you'll have a product advisor, and then myself is a reference point as well. You did just recently get a new product advisor. I apologize, I don't remember his name off the top of my head, but they will be joining us in just a little bit. So we'll be able to ask them any questions or any further information that they have, and you'll be able to at least say hi. So members rely on ODB data to support cost management initiatives, information there on how we've been able to, or excuse me, how other organizations have been able to have some cost savings around that. And then the organizations that routinely use the ODB have been able to realize some large savings in dollars as well. So you can see it below the list of some of those effective users. We do have some case studies for that as well that I believe are already available online, but if not, I can help you guys find those. Again, here to connect you with any of those people that you are interested in connecting with. I was talking to Dr. Is it Shakir? Is that how you say your name? Earlier about that, and just saying more than happy to connect you with people. But as Todd and I ran into, we reached out to Stanford and asked for their assistance to talk about how they do their mortality reviews, and swiftly got a no, not interested at this time. So more than happy to attempt to connect. I can't always guarantee that people are willing to, but some of those top performers, they almost get hounded all the time with getting requests, but most of the time they are okay with reviewing and or connecting, but sometimes they can get a little overwhelmed as well. So any questions, comments, concerns yet? All right. Again, executive sponsor, ODB coordinators, here's some opportunities and or role clarifications for those as well. And then effective performance. This is also for not only the ODB, but the CDB as well. So you can see that once you have that executive leadership support, that also just kind of trickles down, and the higher engagement that you can get throughout the organization, the better. Thanks, Matt. And then member staff requirements. I know that this is in conversation through hiring a new staff member to be able to help you all with this, but this is kind of what we anticipate or what we recommend for FTE requirements. And it's always just kind of good information to have from a Vizient perspective, what we recommend on the hospital side of things as well. And then again, establishing infrastructure. So when you are talking about the CDB and how you guys want to structure all of that, you would also want to talk about and or integrate some of the ODB information into that as well, and just be able to know and align some of that information across the tools so that everybody's kind of on the same page about what's available, what's accessible to everyone. And then again, working with Vizient teams and what the expectation is for us there as well. Here's some more additional resources. So we do have our annual conferences coming up before, and Tom may or may not know about this, but I think before they used to have a whole separate ODB conference similar to the summit that we provide for the CDB. Now it is virtual. I think that was kind of trending that way prior to COVID, but COVID, definitely pushed it to be a more virtual opportunity. And the nice thing about this is that I think it's 2-hour blocks from the 5th to the 9th. And so you get little bits of information instead of these long bits, and can make it more usable and more accessible to people to be able to attend the information as well. So that is a great resource, lots of learning, lots of, again, information sharing during those as well. All right, what questions do we have? Any, do we know is our ODB people, are they on now? Oh, perfect. All right, and can we see their faces at all if I pull up Zoom? Do we know? Oh, okay. Perfect. Is it, okay, can they hear me right now?
Hey, Christina, I can hear you. Can you
Okay,
hear me?
perfect. We can.
Okay.
All right. And I forget, is it CPSC first? Who is talking?
Yeah,
Sorry, who is on
CPSC.
the line?
It's me, Amir, and Jake's with me.
Okay, perfect. Awesome. Thanks. So I will do you have like a presentation or anything that you wanted to share, or?
Yes, I believe Jake's going to be leading today.
Okay, perfect. So that will be our Jake Langley. If you guys have not met him yet, I believe some of you were on the call with the CPSC lead, Jake Langley, and then Amir is here with us as well. And as I was telling you guys about the product advisors, Amir is your product advisor for CPSC. So how do I get them to be able to? Oh, okay. Oops, there we go. Perfect.
How does that look, Christina?
That is perfect. Thanks. Thanks, Jake. Oh, okay. Just this one. There we go. Okay. Put you down at the bottom. All right. Go for it.
Okay. All right. So I thought what I could do, and it's hard for us to hear any questions in the audience. So if we have any of those, Christina, could you relay back to us?
We'll love to.
Okay, thank you. So what I thought we could do is just go through some introductions of myself, Amir. You all have met Christina, obviously, and then talk through a bit of overview around the CPSC just to make sure everybody in the room has a good understanding really of what we do, the data we bring in, the benchmarking we offer, all of that, and how it fits in with other work that happens across Vizient. And if we need to skip over anything, Christina, due to time, or you've already covered it, please do let me know. I'll be happy to move at whatever pace makes the most sense for everybody.
Perfect. Thanks, sir.
All right. So as was mentioned, Amir's on the line as well. Amir is your product advisor for OU Health. He's specifically dedicated to you and your use of the CPSC, the Clinical Practice Solution Center. So any questions related to the CPSC and how it can be used to look at performance and help drive improvement, certainly feel free to funnel those questions through Christina or Amir, both of whom are on hand to support you in your use of CPSC. So just in a nutshell, the CPSC really is not dissimilar from any other tool that we have here at Vizient in the sense that we're bringing in data from a number of different sources across organizations nationwide in order to create these comparative databases and produce benchmarking that can be used to help drive improvement and identify gaps in performance within your organization. So from an OU Health perspective, we've got a number of different data elements that we have coming through. We've got professional fee billing data, which will be CPT level billing data for both physicians and APPs across the organization. We've got ambulatory scheduling data coming over at the visit level. We've got invoice level payment detail from more of a revenue cycle perspective. So all of these different data feeds are coming through on a monthly basis to the CPSC team from OU Health, and we use those to populate databases on our side of things that ultimately power web-based reporting tools and benchmarking that you all have access to as members of the Clinical Practice Solution Center. And then the other thing that's very beneficial and is relatively recent in the history of CPSC and Vizient is this ability that we now have to put together data from the CPSC with data from the clinical database, the CDB, and we can match data at the patient level in order to help organizations look at metrics and performance around things like ambulatory quality, patients in the care continuum, and all of those sorts of metrics that could rely and do rely on understanding how patients are interacting with your health system, both on the outpatient and inpatient side of things. So as we think about the CPSC and we think about all the different components that go into it, all these different data elements certainly are foundational. And then all of the services and supports that Christina's talked about for the CPSC, the CDB, ODB, et cetera, both in the form of tools, but then also in the form of services and collaboration, are there for CPSC as well. So we talked about just a minute ago around ODB and the ability you have to connect with peers there. Same thing applies for CPSC. Same thing applies for tapping into myself and Christina and Amir and others to make sure that you fully get value out of the CPSC program. And then from a data and benchmarking perspective, what's great for OU Health is that you all have essentially everything that we have to offer through the CPSC. So what I mean by that is you're sending over to us your professional fee billing data, that CPT level billing data. You're sending over to us your ambulatory scheduling data, and we also get that invoice level reimbursement or payment information. And all of those things allow us to offer you benchmarks for the first 3 buckets you see on this slide. So clinical operations, access and throughput, and rev cycle are all things that you have access to. And then that 4th bucket there around quality and the continuum of care, the good news on that front is that we have the data within the CPSC and across Vizient and the CDB to give you insights around these metrics you see listed here. There's just one last hurdle we have to go through in the form of a data linking agreement that says, yes, Vizient has the rights to put data together on your behalf. So once that's signed, we'll be able to put these metrics together for you. Again, based on data we already have in-house for OU Health. So we're hoping and looking forward to being able to put those metrics together for you in the very near future. So as we think about the different domains listed here, so clinical operations, really focusing on things that are core blocking and tackling metrics and indicators, if you will, for overall practice management. So overall productivity of clinicians, looking at mix of services provided, billing patterns, looking at how we're charging for services from more of a financial perspective, but then also looking at things like your mix of new versus established patients across different clinical areas, looking at how that is impacted or impacts overall productivity of providers, but then also tying that to access and throughput in that 2nd bucket. So bringing together the billing data and the scheduling data to look at things like new patient timely access. So the percentage of your new patients that you see within 7 days or 10 days or 14 days, what's your median schedule lag for new patients, that sort of thing. And we can also take a look at arrival metrics, so things like no-show rates and bump rates and last-minute cancellations by your patients, really to get an understanding of how efficiently you're able to get those patients who you've scheduled in to see your providers. And then you can understand from there what the impacts are in terms of overall clinical operations, financial performance, et cetera, and ultimately how that ties into practice performance and overall practice health across the organization. And then from a rev cycle perspective, understanding those key performance indicators that are very important to practice revenue cycle managers, so net collection rates and AR stats, so accounts receivable, looking at payment per RVU, so whether it's work RVU or total RVU, we have those metrics. Looking at denial rates and reasons for those denials and looking at resolution rates on those denials, making sure that you're getting paid for those services that you provide at the rate that you expect to be paid from your payers. So looking at all of those together is a tremendous benefit of the CPSC revenue cycle suite. And then on the quality side of things, it's really interesting what we're able to do in leveraging the ARC prevention quality indicators, that software. We can run that against the clinical database, the CDB, to find those admissions for those potentially avoidable conditions, or those admissions that are potentially avoidable, that are related to both the chronic and acute conditions that are identified by ARC for those PQIs. So we can find those patients within the CDB. We can go back to the CPSC, find those individuals before they're admitted to the hospital. We can see which of them have had touch points, are under the the management of OU Health physicians prior to their admission. So it's a nice way to understand the patterns of care that lead up to, or the lack of care that leads up to those admissions. And then the flip side of that is once the patient, has been admitted, say it's heart failure, once that heart failure patient is discharged, we can go back and understand what sort of follow-up care does or does not happen with those patients post-discharge. So it could be the case that we're looking for follow-up within 7 days, could be looking at follow-up within 14 days. But the idea there is to make sure that that timely post-discharge follow-up happens to avoid things like complications and readmissions further down the road. The other thing I'll note on this slide is that we have a lot of detail that's underlying all these metrics. So we talked about the billing data, we talked about the scheduling data. There are a lot of different data elements, in particular related to provider details and nuance, but then also related to patient demographics that we can really take advantage of and look at from a number of different perspectives that may not necessarily be part of the web-based tools that CPSC has to offer. So we've got the ability to look at provider subspecialization, looking at the diagnosis codes of individual patients that they care for, so we can find small cohorts of providers across the country that care for the same sorts of patients. We can look at things like telehealth adoption, what sort of services lend themselves well to telehealth, and what do you look like relative to your peers across the country, or what do you look like regionally in terms of your use of virtual visits versus in-person care. We've got the ability to look at things like, as we see new patients in the organization, what does that mean in terms of downstream care? What sort of diagnostic work happens with those patients? What sort of procedural work happens with those patients? If they come into primary care, who else do they see across the organization? Are they admitted to the hospital? Those are all sort of the temporal views that we can see within CPSC, and by combining CPSC data with the CDB data, we can get that rich picture of performance across the organization. We also do a lot of work around financial impact of things like changes to the Medicare physician fee schedule. That it's this time of year where we're going through those changes and really helping organizations to model what those impacts look like for their government payers, and then ultimately those sorts of changes will most likely impact your commercial payers as well. We have the ability to look at things like HCC scores and RAF scores, support you in the improvement of those. And we're also happy to send data back to you as an organization. So once you've submitted data to the CPSC, to Vizient, we can clean that data, we can ingest it and enrich it, and ultimately send it back to you if you've got the need to populate that into your own data warehouse, or to populate your own reporting tools internally. We're happy to help make that happen as well.
Hey, Jake.
Yes.
Jake, so why is there a yellow mark instead of the green check mark next to the?
Yeah, great question. So I alluded to this a little bit, but the reason that we've got the yellow mark there is because while we have the foundational data elements to put metrics like the ones you see listed here together, we are missing that data linking agreement, Christina, the one I think we've been going back and forth and talking about that one.
Yes.
With OU Health. But once we have that, we've got everything we need to produce these metrics. But until we have that piece of paper signed, we're not allowed to combine the CPSC and CDB data. Does that help?
Yep, absolutely. I wasn't sure if that was on our end or on OU's end. So yes, I think they have. Yep, they're waiting on us, Jake.
Okay. Okay. And then this next slide, I'm not going to go through in a whole lot of detail here, but these are just sort of the top questions that folks are asking. Not rocket science by any means, but really just understanding from an operations and access and rev cycle perspective, what are the key use cases for CPSC data? This is not an exhaustive list by any means, but really as you're looking at it, feel free to look at what you see here and ask these questions, but also know that you can put different variations of these questions together to ask more nuanced versions of them. So as we think about what does it mean to have non-arrivals within the clinic? Well, do we have no-show rates that are going to impact our ability for providers to hit their productivity benchmarks? Or when we look at the coding patterns of our physicians in the ambulatory space, does that impact our revenue cycle performance, our overall reimbursements for services? So just know that These are all sort of discrete metrics and benchmarks that you have access to. But then when you start to put all of them together, that's really where you start to get a much more holistic, much more detailed view of performance, and help you understand really why things may look the way they do relative to benchmarks that CPSC puts out. And then I wanted to include this slide just to make sure you understand who you're being benchmarked against nationally. So as we look at this list, you'll see a very large representation of academic medical centers and faculty practice groups across the country. These are all groups that are used, again, for that cohort against which you're benchmarked. Every single year, we put together these benchmarks around clinical operations and around access to care and revenue cycle performance. And we draw upon the data that are collected from these organizations to create those benchmarks here within the CPSC program. And then as we talk about those benchmarks, just know that we're not just saying here's one single benchmark for the organization, but rather we're producing specialty and subspecialty levels of benchmarking detail. So you can go through and say, for my oncology service, here's what the breast cancer benchmark looks like for productivity for a provider versus the head and neck cancer productivity benchmark, or here's what the coding patterns look like for corneal and refractive surgery and ophthalmology versus a glaucoma specialist within ophthalmology. So just know that as you're thinking about the providers, the clinicians across your organization, there is mapping at the specialty and subspecialty level that happens to make sure that we've got the right comparison relative to benchmarks within the CPSC program. So this is the first half of the CPSC specialties that are out there. Here's the second half. And as I talk about this particular slide, the thing I'll note is that this is not a static list by any means. Every single year, we are looking to grow the number of specialties and subspecialties that we benchmark against. And we do that by listening to our membership as you all are asking us for a breakout of this specialty or that specialty. Once we hear that enough, once we get to critical mass for those requests, we're able to go through our database and find those individual clinicians that fit the bill to be broken out from the general specialty. And we can say, based on your pattern of diagnosis codes of patients you care for, based on the CPT code billing that you've got, the procedural work that you do, we really do believe that you ought to be mapped over here. We send that back to our membership and they say, yes, it makes sense to remap Dr. Jake to whatever specialty we've suggested. And from there, we can start to create these new benchmarks every year within CPSC. And then this slide, we won't talk a whole ton of detail around this slide, but it's going to be there as a point of reference for you. And Christina and Amir and I happy to share these slides, after the session here today. But we just want to make sure that as you think about CPSC, there are a lot of different places where you can go to get data, a lot of different tools that you can tap into. So this is just sort of a cheat sheet to say, here's all the different places to find information, and here's what's included in those different locations, and it's sort of the form that the information takes. So whether it's more of a dashboard format, whether it's a tabular report, more like a pivot table in Excel, we're really calling that out here as a way for you to better understand where you might go to find different pieces of information from the CPSC. All right, so let me pause there. Christina, any questions? Moment.
I do not see any right now.
Okay. And then just a time check, 10 minutes left, or how many more? Okay.
Yeah, I would say the ODB coordinators are coming on at usually about 3:30, but
Okay.
I'm sure they're okay with holding for a little bit too if you need to.
All right. Sounds good. Thank you. Okay, so next sort of portion of our conversation here is not just focused around what you have at OU Health from CPSC, but who we would like to be working with and who we are working with to leverage the data from CPSC to support OU Health. So as I was listening to Christina talk about ODB and CDB and all the different roles that are out there, you're going to see in these next couple of slides a lot of overlap, a lot of the same sorts of ideas in terms of who's doing what and the roles that are out there in CPSC. But just know that that's by design, and that as you think about all the different products that are out there, from a data perspective and analytics perspective across Vizient, we're trying to make each of them as close to one another as possible in terms of the people that you interact with and the folks that we interact with to make them as valuable as possible. So from our perspective, from my team, from Amir and from Christina, we're really looking to partner with you from what we call the product advisor perspective, that's Amir, as well as the operations and quality executive, that's Christina, to be an extension of your staff, to support you in the use of data, whether that's making sure we can find insights on your behalf, working with you on analytic requests that come through that you don't quite know how to work through in the CPSC data, working through training, education with your teams to make sure that not only can we support you and pull data for you, but that you know how to do that as well. And then also just making sure that we understand from a practice perspective, from an operations and finance and access perspective, what are the most important things to you and how can we leverage the CPSC to support you in achieving those goals. So really, working across our team here at Vizient to make sure that you realize as much value as you can as OU Health, the member of CPSC and the member of Vizient. And then we also are there, as Christina talked about earlier, to help you connect with your peers across the country. There's a little bit less transparency within the CPSC program. For whatever reason, practices historically have just been more guarded, less willing to share data than hospitals have across the country. So while we are able to connect you with your peers, there's more of a facilitation that has to happen through the CPSC program. So if you want to know who's doing well on a particular metric or who's a top performer for whatever it is that you're looking at, we can help you find those people and help make those connections. But it's really more of, we play the intermediary in making that happen. So just know that we can do that. We're happy to do it. So if you have those questions, feel free to reach out to us. We'll be more than happy to facilitate those introductions. We also put together white papers, case studies, just to make sure that leading practices and great stories are shared across our membership. And then we also, over the course of the past couple of years, have introduced what we refer to as roundtables across the CPSC program, where we focus on specific topics that are of importance at the time. So looking at things like telehealth, and then last year it was the E&M changes that impacted billing for services in the outpatient setting. We've talked about the usage of APPs across our membership and how that is impacted overall performance. We've talked about split shared billing. So if any of these topics resonate with you, if any of these are of interest to you, just know that we will have these roundtables typically on a quarterly basis throughout each year, and we invite members from across the country to come speak and be part of that conversation around these different topics that are of interest to the broader CPSC membership. All right, so that's us. And from your perspective on the OU Health side, we do have a few different roles. There is a member champion role that kind of is emerging around the CPSC program. It's not quite, it's not all the way there like it is for the CDB and the ODB. But as we think about the roles that are important from a CPSC program perspective, certainly the executive sponsor as the person who's the leader, the advocate, for the CPSC at the member organization. That's a huge role for us that we feel is integral in making sure that the CPSC is successful and that organizations are successful in using the CPSC to drive improvements. The CPSC coordinator really as the key super user, the conduit between Vizient and CPSC and the member organization, making sure that you're there and able to be supported by the product advisor and by the operations and quality executive to make sure that you're getting full value out of the product, out of the data, the benchmarks that are available to you, and just making sure that you're a resource for others across the organization who may have questions about the CPSC. Not that you have to be the expert in everything, but at least you're somebody who can be, at the middle of the hub and spoke, so to speak, so you can connect the right people with one another who need to be connected. And then from a CFT, or not CFT, we talk about practice all the time, so I'd say CFT. From an FTE perspective, It's really as much as you would like to make out of the role. Typically, we see anywhere from a quarter to a half FTE across one person or multiple people. Cumulative, so not half an FTE across multiple people, but you combine all their efforts together. We see that that's really what it takes to drive the use of CPSC effectively across organizations. So making sure you're able to work with us, making sure you're able to work with other folks across the organization who are looking to leverage CPSC to drive improvement. And then the last role is more of a technical person, more of an IT or data individual who's able to help with the build and submission of data to the CPSC, who understands from a validation perspective what has to happen to make sure data are good and trustworthy within the CPSC database, and works with our team, our data intake staff on a monthly basis to ensure that we get good, clean, quality data into our tools so that you all can feel comfortable and confident in the insights that come out of the CPSC tools within your organization. So what you see here on the right-hand side are the individuals who we have on point as of today for these roles. So we currently do not have an executive sponsor identified, so we'd be happy to have that conversation probably offline just to make sure we get the right person or people on point there. From a CPSC coordinator perspective, Bob and Dylan have been integral in supporting us in the use of CPSC data over the years. So thank you to both of you for that. And then from a technical perspective, Don and Desiree have been around to support the submission of data and making sure things are where they need to be from a data intake perspective here within CPSC.
Dylan, did you have something? Hold on 1 second. 1 second. He can't hear you, so.
Jake, I think you identify a really good opportunity, which is like our CPSC coordinators. You have Bob and I listed. I mean, as much as I would love to give half my time dedicated to the particular tool, this is a problem that we just have with our Vizient tools and kind of the level setting from a vision perspective that we need to help kind of solve. I think with this presentation around CPSC, it would be greatly helpful if we set up some time with Mandy Newman and her leadership team, in addition to Dr. Dunn, our CPE, to determine who we want our executive sponsor be, who we need from a coordinator perspective. We're happy to help from a data submission perspective, but I mean, if OU Health wants to make CPSC as an initiative that we want to undertake, it's really gonna have to be owned by really the business side or someone at least. So
Yep. Yeah, and that makes sense to me. So just to support that conversation, and I think it's one that lends itself to a follow-up for sure, is really just this sort of review of what we typically see across the CPSC. So there's, generally speaking, a core group of users within each organization who's a part of the CPSC, who understand the data, the nuances, the ins and outs, and the general business impacts of what these metrics mean. So it may not be that you're the expert, but you at least understand the implications, right, of what it means to have performance in one direction or the other within the CPSC tools. And typically this core group is able to support other folks across the organization as sort of that first line of defense in using CPSC data, answering questions, that sort of thing. So we tend to see that this falls within the practice finance team. And historically speaking, that's been the case because of the billing data piece of CPSC being foundational. But now that we have more and more ambulatory access as part of the CPSC, more and more quality and the care continuum making their way into the CPSC, certainly practice operations folks are very interested in what we have within CPSC. And then certainly, as you mentioned, Dylan, from a data perspective, decision support perspective, you can't understate the need to have folks who understand where data come from and how they get sent over to CPSC in terms of the importance for this core team of CPSC users. And then what's a little bit unique around the CPSC, maybe more so from other tools that we have at Vizient, is that there's oftentimes a need to have more department or division-based users of the CPSC tools. So whether those be department chairs or administrators, business managers of different clinics, et cetera, or the analysts who support those individuals, there's oftentimes a need to have a person or people who really know the specific nuance around providers and clinics on an individual basis across the organization. So just know that while we would not expect these people to be the everyday contact for us at CPSC, but these are folks that tend to really like to use the data and use it for operational and financial decision making within each of these different departments or divisions across the organization. And then the last group I've got called out here, and I've done this because it's a little bit separate from the core CPSC tool set and the ambulatory quality and accountability study, which is the framework that leverages data from CPSC and the CDB together to look at holistic ambulatory performance, which is inclusive of ambulatory quality in the care continuum. This oftentimes is just a different group of people than we typically see from the practice finance or practice operations teams. So just know that there are lots of organizations across the country that have sort of a quality liaison or an AQA liaison who's on point for really helping to facilitate the use of and interest in the ambulatory quality and accountability, the AQA, here within the CPSC. So I would just throw that out there as another potential constituents, another group that may be interested in CPSC. Also, from a population health perspective, folks who are in that realm also find value in seeing the ambulatory quality and accountability data as well. Okay, so I'm a couple minutes past. Christina, any other questions or any other contents that we can cover for the group here today?
Any other questions you guys have? Excuse me. No? All right. Well, thank you so much, Jake and Amir. I really appreciate your time with all of this, and we will let our ODB subject matter experts take it over now.
All right, thanks. Take care.
Thank you.
Thank you.
All right, Rich, are you on?
I am on, and we have Tom Noe from our team also.
Perfect. I will let you guys introduce yourselves. Do you have a presentation or anything along those lines, or you just want to chat and maybe talk about best practices, etc.?
No, we don't have a formal presentation, but we'll be happy to answer whatever questions the OU team has. My name is Rich Hodges. I'm a manager on the product delivery team for ODB. I have not had the opportunity to work with OU Health. Tom Noe, my colleague who is on the call today, will be serving in an interim role as your product advisor, basically your subject matter expert for the ODB. And I'll let him introduce himself.
Thanks, Rich. Yeah, my name is Tom Noe. I am the product advisor for ODB, and I, like Rich said, will be your interim product advisor for any questions that you have on the tool or any other issues around reporting with the tool.
Perfect. From the OU side, I believe it was, is it Kimming? Is that how you say his name? Shiming, okay. And then who else was entering or helping to assist enter data? Okay, perfect. Are they here today? No. Okay, all right, perfect. So I know that they were working pretty robustly, or I believe they were working pretty robustly with Michelle Wickman to get some data in. They were trying to get the Q3 data in instead of backloading data. And Rich, I believe that they were able to get that in, if I remember correctly, or were we still working to do that?
I'm sorry, go ahead.
I was going to say, Rich, I can answer that. As of right now, the data is not in for Q3.
Okay, perfect. And we'll get a plan started to get them connected, Shimming and Tom, sorry. And any other, like, maybe we could start with some best practices that you guys are aware of that other organizations are doing well. I had shared earlier some, and let me pull this back up to see if you guys can see this, just so you know where we kind of already talked about some of the infrastructure and a few of the best practices for the operational database. Let me share my screen with you guys so you can see that as well. I think I hit it. Is it up at the top? Say what? Oh, there it is. Oh my gosh. Sooner or later I'll get a hold of this. All right. So you guys should be able to see that as well. So we did talk through the operational, you know, some of the just basics of the ODB, et cetera, and then talked through, you know, the features of it, et cetera. But what we didn't have a ton of was best practices. So Rich, if you didn't mind maybe talking through some of what you've seen from organizations as best practice for getting the data, whether it be in there or how they use the data as well, I think would be helpful.
Well, absolutely. You know, the obvious priority would be to, you know, to get the data in and get caught up with the current time period. If we have an identified program coordinator, and see, and my understanding is, and I apologize for not having worked with OU Health, you do not have a designated coordinator at this time, or they do?
They do not have somebody identified specifically
Okay.
there in the hiring process.
Right.
They were just working with
Gotcha.
two individuals,
Okay.
I believe, to get as much information in as they could.
Okay, fantastic. Well, like I said, we have a couple of options there. Once a program coordinator is identified, your product advisor can work with that person to get them trained and up to speed on ODB, the data submission process specifically. We have a number of training options through online courses as well as one-on-one instruction. So we're here to support you. As I mentioned, Tom is going to be your interim support. We had a person leave our team who was your ODB coordinator. When that position gets replaced, we'll assign someone for sure. So we'll be happy to work with that person. In the interim, one option that I would suggest is what we call a GFAC only submission. And GFAC basically refers to your facility level statistics. That would be your income statement, your balance sheet, and some global statistics. It's not department level detail, but it does at least give you some global comparative data to show you where some of your strengths and weaknesses are. So that's a good starting point. And it's something that even without an ODB coordinator, we could coach you through. Now, the deadline for the submission is actually tomorrow at 7:30. So I don't know in terms of, realistically, are you going to be able to put that together in one day? But we're happy to work with you. If the process of recruiting someone, who knows when that's going to happen. Tom can work with you to at least work on a GFAC only submission. So I highly recommend that. As far as best practices, what we see, the crucial element is your executive support. The executive team, really drives the ODB, helps set goals and objectives. We work very closely with the executive team as well as the ODB coordinator to put a reporting infrastructure in place. We'll work with you to develop or to identify an appropriate peer group. That's always a big issue. Who do you compare your data to? And we can work with you on the reporting infrastructure to push that data out and work with your managers to understand where those opportunities are with that executive support from senior leadership. I think the key best practice that we've seen when we look at other members who have been successful is they've really integrated it into their business practices. Our members use it for a lot of different purposes. Probably one of the most common one is physician control. With all the emphasis on labor management, ODB gives you a great source of sort of a source of truth to look at, the need for new FTEs, new positions, replacing old positions. Very common use. A lot of our hospitals will have position control committees where whenever new positions are requested, they have the ODB data available to kind of assess, well, where do we stand now compared to our peers? Is the staffing levels in this department on the higher end or the lower end? It gives you sort of an objective way to assess the need for those positions. That sometimes you can have a cost avoidance by, kind of looking at that and saying, based on the data, your staffing model seems to be in a good place. Then we can work with you to maybe reach out to your peers and identify where the differences are and what the differences in processes are between you and your peers that allows them to operate in a more efficient level. So that's probably the most common use. Many of our members use that as part of their budget processes to assess allocation of resources, our supply cost, our labor cost, how do we use that? We use it very commonly as part of your labor productivity management. I don't know if you have a formal labor productivity management tool. We have members that use the benchmark data to establish targets for internal labor productivity systems. Productivity is probably the single most common use for the tool, with all the emphasis on labor management. So we work very closely with each of our members to come up with a plan for them based on what their needs are. If you have specific challenges, specific financial goals, we can work with you to help you identify some strategies to help reach those goals. And that's where your product advisor comes in. So, we're happy to offer those resources and we want to get to know you better so that we can understand what that plan needs to be. But we'll provide those resources to you going forward. But again, the key here, I guess, as a first step is to get that coordinator in place and get those data submissions going again. And I'm curious, being new to OU, and pardon me, to what extent have you used the tool in the past? I know there's no recent data, but I know you've used it in the past. Have you actively used the tool? And if I could ask, how you've used it and whether you had success.
Does anybody here know the answer to that question, I guess?
I'm sorry, I can't hear.
He was oh, yeah, hold on. One second. They just can't hear you on the phone.
Sorry.
So I think we've had 2 successful submissions, if my memory serves, Dylan.
Okay.
The initial information that came back had some data that was, I think, questionable in the summarization of it when we reviewed it as an exec team.
Okay.
And then beyond that, I think when we got into the tool, there was, as you said, there's training opportunities and all of that, but between myself, my CFO looking through it, it was like, there's so much reporting and all that in it that it was taking so much time to do that.
Yeah.
It needed to be ultimately delivered to us from our role that we're trying to fill again.
Yeah.
So I would say little to none.
Okay.
Great. Well, thank you for that.
Not great. It's one that we were very excited about for a long period of time. It was an extreme challenge until we got Leslie, the former person, to actually put in all the data.
Yeah.
It was an extreme challenge to get that data submission with all of our systems that are pulling from and all the various people. So that part had to get solved, which it did. But then we got back to where we were in square one. So
well, we're here to help. Yeah.
We talk about transparency in the database. So I'll be transparent with you. We recognize that the data submission process is more complex and time consuming than it needs to be. And one of Vizient's priorities right now, we have multiple initiatives going, is to simplify that and automate that process. If you think about the nature of the data, it kind of has to be complex, but I think there's things that we can do to help you with that. Again, that coordinator is crucial. Another service that we offer that we can provide more information if you're interested in is data submission services, where we would provide a resource to work with you on the data submission. Now, you would still need to have a coordinator, because obviously Vizient wouldn't have the ability to go into your payroll system or your general ledger and do those extracts. And we can't collect some of the statistics, but basically with the the data submission services, you have a Vizient experts that basically takes the data from your organization, loads it in the tool, and makes sure that the data structure is complete and accurate. So they manage all of your mappings, for example. They make sure that the normalizations, which if you're familiar with that process, it's fairly complex. They make sure that the normalizations are accurate and up to date. So that's a resource we could offer if you're interested in learning more, but that's obviously the first thing. And then if it makes you feel any better, it's common. I always tell people your first data submission has to be a first draft. Because of the complexity, it's very common to submit data. You know, you look at it and it looks clean. You start looking at reports and you see anomalies like that doesn't look right or that doesn't look right. Then we kind of do a root cause analysis and we find out, things like maybe a manager wasn't exactly clear on a statistic that they provided. So we had to clarify that for them. It's normal to find that in the first submission, but those things kind of, as you said, they get cleaned up and then you move forward and you have better data. As far as the reporting side, yes.
Just before you go too far down the road. So part of the contract that OU has currently is for a limited part of time until they get somebody hired, but that data submission services as well. So they are looking at that. Yeah.
Thank you. I wasn't aware
I
of
know
that,
you're not
Christina.
involved in that aspect of the work. So just for your own information.
Well, that's fantastic. And that's something, that team is actually pretty flexible with that. If you're interested in a longer term commitment of data submission services, they're happy to do that. But they commonly, come in cases like this where you've got to say a new person trying to get up to speed rather, and they'll work very closely. So we'll be happy to work with you on that side. But again, even with the data submission services, you still need that coordinator to sort of feed data to us. So the rule of thumb is with data submission services, we have some members that engage with us on that on a long-term basis, and it probably reduces the workload on your end by 50 to 60%. So there's still some work involved, but it definitely frees up bandwidth, and we think it also helps ensure some of the data quality and integrity too. So again, something we're willing to work with you on. On the reporting side, that's a really big part of the product advisor's job, and we work very closely with Christina, your operations and quality executive, on that. We can absolutely give you guidance as to the types of reporting infrastructure that our other members have in place. I mean, we can provide for you some executive level reports that sort of summarize what the data says at a department level. And then to the other extreme, we can give you some very detailed, deep dive information that, we can work with your managers on to help sort of do a root cause analysis and see what could be driving some of those variances. So we have a wide range of reporting options available within the tool. We also have curated reports that we provide to you on the ODB website, and I think Christina may have covered those with you in the past, where every quarter Vizient takes a data feed from the ODB tool, and we build some curated reports that we post for you. These are executive level reports that sort of show you where your top opportunities are, and those are posted. The long-term plan at ODB is to integrate those two things. Vizient acquired this tool from IBM. We're still basically dealing with the legacy IBM tool, but we're in the process of integrating them and building some of those reports into the tool itself. I know we're right now starting to build in things like the high overtime report right into the tool. So there's a lot of exciting developments going on in terms of the reporting infrastructure. Oh my gosh, I believe we're rolling it out this December. And if I'm telling you something wrong, I'll apologize in advance. I get confused on the roadmap myself sometimes. But we're also putting into place an executive dashboard, which we're really excited about, because that's a very visual, graphical representation of your ODB data that you can sort of work with interactively. So that's a really exciting enhancement. So, once we get that data infrastructure in place, Tom can work very close with you on the reporting side to also create that. I think if I said reporting, I misspoke. Once we get the data infrastructure, we can help coordinate the reporting infrastructure. And we can also work with Christina to put together some executive reviews for you, where we can have, we can sit down on our end and sort of filter through all that information and try to, put that into executive summary level presentations for you. So we'll be happy to work with you to help you get the maximum value out of the tool.
Any questions that you guys have for Rich or Tom about how the tool is used or information that goes into it, etc.? Oops. Yeah, so Dylan had just said it kind of comes back to the same thing that we're running into with CPSC, as well as who's the exec sponsor, who's the member champion, you know, who from that executive leadership team. You know.
Yeah, good point. We, you know, those roles were really crucial in making sure that we have that identified is you know, having that person that gives us that direction, and that strategic direction is really crucial.
Yep. Perfect. Any other questions that you guys have for the ODB team? Thank you all for joining us. I appreciate it, Rich and Tom, and nice to meet you, Tom. So I haven't even had the opportunity to meet him yet. So just got assigned yesterday, right? Or today or this morning or something along those lines. So I'm glad that you were able to join us. So, all right. Well, thank you for your time, and we'll be in contact with you, Tom and Rich as well. So
okay, thank you very much.
All right, thanks.
Thank you. See ya. All right. So for the next about hour, if we even need an hour, I was going to kind of talk through with you guys and really have more of a conversation about what you would like to see as best practices. Todd, I'm not sure if you want to talk about, and I know we kind of briefly touched on that triad, but you know, when Steve talks about the structure, process, outcomes, you know, what kind of visioning do you all have for that, and or do you want to have some more conversations, best practice, conversations about best practices, or maybe is this not the right group? Maybe do we need to have a, you know, a separate kind of conversation at a later time? So I was talking to Dr. Shakir yesterday about one of my organizations actually has a physician. Now I know probably not doable for every organization, but she does 1 week of bedside care and then 1 week of reviewing patient deaths. However, she doesn't review every patient death. She only reviews those that are in the well below and the below category for the acuities, or excuse me, expected mortalities. And her and I talk probably on a weekly, every time she's reviewing them, she always sends me something to ask, hey, how does this apply? Or, you know, how can we improve on XYZ? So that level of engagement from that physician perspective really helped to drive some improvement for them. Just identifying where we have documentation opportunities to start, right? That's where they just decided that they were going to start. So, you know, maybe you don't have somebody that can review all in the well below or the below categories, but maybe you can take those 41 deaths that are in the low severity DRGs and review those 41. Again, it wouldn't have to be all 41 at once, but maybe you take the 41 that are also in the well below or the below and identify a way to do that too. So yeah. Yep. Yes. Oh yeah. Yep. Yeah. Absolutely. And her ISIT team sends that to her, and that's how she gets that list. And then she goes in and drills into that patient level detail. So I guess the push happens from the IT part, and then she gets to do, you know, some of the pull. So yeah. Yep. Yeah. Yep. Yeah. Perfect. So am I. Correct. Yes. Yeah. Correct. Yeah. Yeah.
That's the most very basic of the opportunity for you all here is that you have many more of those than other ones.
Yep.
So, look at that patient with hemorrhoids. Yeah, that was one issue on mistake that would have increased the expected value of reimbursement. But you're going to find others that you can take a look at and say, well, it is one day they got a complication, day 10 that's going to be addressed. So you want to be able to act on all of those, not just quality.
Yep. Exactly. What other questions or, concerns and or ideas for improvement have you guys thought of as you've seen these presentations? Because it can be overwhelming. I fully understand that feeling of, okay, now what, and I would love to hear kind of your thoughts on if you have a thought about now what, right? Has everybody, before we get too far, has everybody seen the Q&A study here? Have you all seen what the Q&A? Have you? I can pull it up. So while you talk, I can. Oh, okay. Oh, the general medicine one. Yeah.
Was quite high, but our expected actually was higher than that. It was higher than the HLA. So that actually surprised us a bit. Well, surprised us a bit. But if you go around to the adult hospital, yeah, you guys know the transfer. So that, and then at the same time, expected is already higher than that. Patients dying, and the risk predicted is quite low. So, not sure because when we look at the cancer population, it was almost the opposite of expected. I would again, I can write this report. Take a look at it. You look at the top 10 organizations compared to a effective mortality overall, it would be a lot. Which means that based on what I've seen, you have to put a situation at a medical center. But when you look at all academic centers that include hospitals that don't have a lot of things like don't have their expected value to be low, so they're bringing that back. So when you look at yourself against all academic expected values, it is about average, but if you compare yourself to those top 10 in terms of have post transfers, I'm guaranteed to be lower. I mean, yes, to be lower. But again, the thing to point out is even on those top 10 transfer sites, their observed overall mortality was a percentage point, 2 percentage points higher. So you have a dual opportunity when it comes to mortality. Lower the O and increase the triple. Yeah, the calculator that you did that example.
Oh, which one? Sorry.
Just an example of the case.
This one.
Yeah.
Yes. Yeah, it's kind of small, isn't it? Okay. And then I think, oops, no. So here, And you may have to help me remember this because I don't remember this specific case. But I believe, oh yes, okay. So at the top is the calculator per the documentation. So it's very similar to what Steve had showed earlier, where so that this is the case profile. This is the risk model calculator. So at the top is the one that would have been there for what the patient currently was documented. So you can see they are documented for the relative expected and the Vizient acuity scale as well below. So if you added the, so it is the DNR, then their expected mortality shoots up to above. So just by documenting DNR, now granted, I don't think this patient had a DNR status, correct? No, but the patient was only here for a day. So you can make the argument that, maybe there was an opportunity to have that conversation. So I came from Spectrum Health in Grand Rapids, Michigan. And one of the big pushes that they had, it was probably 2 or 3 years before I left, was documenting DNR status on every single patient that walked in the door. So within, I think it was 24 or 48 hours, it must've been 24. So within 24 hours, they always wanted a DNR status documented. So whether that was yes or no, whatever it might be, they had the conversation. So it's not only that it was documented, but that someone had the conversation with the patient on what their expectations were in case anything happened. Now, I know that it was not 100% documented all the time, but it got pretty darn close, and they did a decent job of trying to get that through to the staff and really having the conversation. So it wasn't just about documentation, it was about having the conversation. And yes. Yes. Correct. Yep, exactly. And we can connect you with those people on, how did you implement that, or how did you sustain it? Because, right, that's kind of the challenge is a lot of times we can get the initial part going, but it's the sustainment efforts that are the challenge. So. Yep. Yeah. Yep. Yep. Yeah. Exactly. Yeah. So here you can see some opportunities, and it's not just about your percent of cases either, but it's that percentile rank. So as Steve says, even when it comes to, malnutrition, we're not asking you to be in the 75th percentile. Don't shoot for the 75th, just shoot for the 10th at this point, right? Like just increase to the 10th and see where that gets you. But as Steve had shared again earlier, we have seen that increase for you all. So just get yourself up to the 10th percentile and see how that helps too. So yeah.
One of the insights way that we're getting patients for the transfer will come to the team that they're gonna come take the care to get the hospital. So I'm gonna get so do everything in the ICU, or you get 2 patient or the best direct for not outpatient discussion about the care, everything, do it for day 3 or 4, and then you set the intense perspective and say, you know what, about what can anywhere.
Yeah.
And this is for that higher mortality.
Mm-hmm. Yep. Yes. Yeah. And I always try to kind of bring it back to the patient, right? Like this is what's best for the patient. It's not about documenting more. It's about accurately capturing what's happening to the patient too. I think back on one of the examples that Steve had brought up was the multiple, like down a little bit further on the list were some things that you were just like, whoa, why is that not moved up? And oh, BMI, that's what it was. Why was a BMI of 45 documented as not present on admission? So, like that, obviously the patient didn't come here, and then I think patients lose weight when they come to the hospital. They definitely don't get to a BMI of 45 by, and so just accurately capturing what the grouping of patients that you have and how severe and how sick they are when they do come in is also important. So, because we know that, maybe you're not that different, but you're probably a little bit different here in this grouping. My sister-in-law worked in Tulsa as a cardiac nurse and said, whoa, I've never seen so many cardiac patients in my life. So. Correct. In the state. Yep. Yep. Yes. Yep. Correct. Yeah. Yeah. Yep. Yep. Yeah. Yeah. Yep. Yeah. Yep. Yep. Yeah. Yeah. Yeah, for sure. Ben Card, is that how you say his last name? I never know. Him and I work pretty closely, and we talk a lot about, how to help with some of those oncology aspects. So, and discuss a lot of the information around the oncology service line as well. So. Yes.
We have great outcomes, but they forget those patients. Some of them, maybe not, but they come back into the other services.
Yep.
With all sorts of other problems, the whole host of services that have to take care of the patient. So you can't attribute that to a service. Yes, he or she gets signed to a diagnosis.
Correct.
Whole bunch.
Yeah. Yeah. Yep. Attribution is huge, and I know that you guys have worked very hard on that in just the last few months to work on the physician attribution and okay. Yes. Yep. So I know that you guys have spent a lot of time on that in the last few months. So perfect. Exactly. And that's some of the data that Steve was talking about too, like focus on the data, but don't focus on the data. It sounds so contradictory, but you want to make sure that your data is clean and accurate, but also know that your outcomes aren't reflective of just the data. It's reflective of the care and some of the documentation as well too. But obviously no physician or nurse comes to work thinking I'm gonna have a bunch of patients die on me today. So we know that you guys are doing good work, and ultimately that's the message that we want to get across too is that we know you're doing good work, and we just want it to be able to reflect in what others see about you all as well.
One of the things that I'll bring up, probably nothing like that. With 107 hospitals that we categorize that. First of all, we categorize that as ADCs, not because of each of the programs, but because of quality, transplant, trauma cases, transfusion from other hospitals, CDC, those. There are 107. When we look overall at those 107, we look at the observed mortality that's occurring in the hospital. You're 107. Hopefully, I don't want you to summon
that you review and then push that down, you know, best practices. Do you guys do any of that? We were implementing that at Spectrum right before I left. That was the team that I had worked on right when I left. So I'm just curious if you guys had heard or worked on CPCs before. No, guessing not. There's so that's an idea, you know, and I think it's very similar to what you guys are talking about, but it is physician led. So they look at least at Spectrum, they looked at, or Corewell, whatever it's called now, they looked at, you know, what are best practices and how can we implement from not only best practices, but also documentation best practices, and ensuring that from the minute the physician or the patient walks in, every physician is following a certain practice. And then if there's a fallout, you go to that specific physician and say, hey, you had a fallout. Why weren't you following best practices? And there was always reasons and valid reasons. We were not trying to make everybody Stepford doctors, you know, where you had to follow certain things. There's always reasons to vary and stray from that practice, but having the why behind the going different ways is always helpful as well. Absolutely. Yep. Yep. Absolutely. Yep. For sure. Yeah. Right. Yep. Yep. Exactly. Right. Yep. Because there may be a why behind it, and it's a good why and or a bad why, right? So, yeah. Yeah. Yep. Yep. Exactly.
I think coming back to Vizient as a whole, I think there's two things. One, Vizient, if Vizient is our North Star, right? We have one of three products that's up. Two tools that were one, I mean, both in contract.
Yep.
Don't have that now. Have executive programs for the midst of improving for ODB, right? But how do we, as a system, we want to make Vizient initiative priority is one, do we propose that we have an executive level steering committee that helps govern, if not help champion tools, build it into the reporting processes, our huddle approach, to really kind of take that and really cascade it in everything that we embody in our operation. I mean, those are aspects that we had done at Kansas, but
yeah,
we changed from where I think that's a couple things that those have really want to get the great power of where you guys are going now as the organization. Vizient really is a data company.
Yep.
And so now you're starting back to data sets that data too, where we're starting to get into some other elements and methods that we historically have not been able to.
Yeah. So from your perspective and or the group's perspective, how can we as Vizient and or I, Tom, help you to get that executive level? I know you have the executive level support, but identification of those executive level leaders. I'm looking to your leaders. So, you know, do you need help from me to help you all identify that? Do you want to spend some time together, you know, working through who, from an organizational perspective, you guys want to identify as those executive champions? You know, how help me help you, right? So I'm here as a resource for you all to help you get those people identified as well, so that then you can move forward with those products and really implement them from the highest level down, or the lowest level up for that matter. CPSC, yeah. Yeah. It's CDB, yeah. Yep, yep. Right. Right. Yep. Oh, no, that's, yeah, excellent. Yep.
That will allow you to be able, the hospital to see the FPSC data, the CPSC. In next year, we're also working to automatically connect those. So write reports out of CDB, looking across the for inpatient, hospital-based outpatient, right to physician health. Because the WNC, which is no longer part of the, I say FPSC, because we written, but they said that this is strictly for the faculty. That's what we say, but then they were requiring
A linking. Those lawyers, they ruin everything. Any other questions, or you guys want to talk about ideas, solutions? All right. Well, thank you all for your time. Really enjoy the engagement. So thank you. Yeah, no problem.